This video is to demonstrate how to create an unscheduled appointment and to do an intake note for a client or consumer. In this situation, if I want to be able to access a client's chart, I can find them under the Patients tab. This should list all of the patients that you currently have. Within that, I can click on it. Anytime I'm going into or meeting with a patient or client, if I know of a phone number that changes or the address that's changing, we want to update that because this is also a tool that is used for coordination of care so that others that are part of the care team will also have access to this information, support roles, etc. I can go into documents. Of course, this one doesn't have because it's a sample chart, but oftentimes, or you should expect that all of your documents, your opening paperwork should all be scanned in here within your within the chart. So if I want to create a note, I can create different types of notes. So if I want to do an intake note, if I'm doing a treatment plan note, a treatment plan, an intake is the first type of note that we want to be able to have. And we do require that all clients, all consumers, all cases have an intake note. All cases also need to have a treatment plan. And then we can get into progress notes. So psychotherapy progress notes are the next most common or the everyday type of note that's done. We don't want process notes. Termination notes are at the end of treatment. If you're doing or you're qualified to do a psychological evaluation and you're doing an evaluation, you can utilize this one. We don't do consultation notes. Contact notes are only done for things that you need to document. So let's say I need to be able to keep track of when I've tried to reach out to a client for, let's say it's court records or whatever that might be. If I'm just trying to reach out, there's not a need to document. I don't need to do a note every time I call someone, but let's say I call, I leave a voicemail, I might document that in a contact note. In general, though, your general interactions, if you're interacting with a family, if you're doing things on behalf of a family like case management supports, that all will be a psychotherapy progress note. And then again, I might have a missed appointment note. We don't use miscellaneous notes. The only thing that really goes into the system are the main notes or intake notes, treatment notes, and progress notes. Everything else can almost be ignored. Psychotherapy intake note is what I'm trying to do right now. It says, hey, you don't have this scheduled. It's not in your to-do list. That's okay. We're going to do an unscheduled note. From here, I'm going to select where is it that I'm having this note. Psychiatric diagnostic evaluation sounds very complicated, but it is the CPT that is done for intake. And so even if you're not a psychiatric provider, it's okay. If you do mental health services, if you provide direct services to clients, this is the code that you use. So I'm going to do that for today, and I'm going to put in today's time, which for me is 5:21, and I do want to have the exact time in the chart. And then at this onset, I might estimate the amount of time that it's going to be for the meeting. So let's say I estimate that it's going to take me 60 minutes. And so I'm going to save my new appointment, which then brings me right into doing my note. Let's say I start to have, I start into the services and I thought we were going to be together for 60 minutes. And it turns out we were together for 115 minutes, or it turns out we were together for only 45 minutes or 43 minutes. And again, you want to be exact in these. Then you can update that header by doing this. If I'm doing the evaluation or the intake assessment, and let's say I'm traveling to the consumer and they're a redeploy client, this is only available for redeploy or WADI clients. If they're a redeploy client, I'm going to put in the number of units traveling with them. And so this is for every 15 minutes. So let's say I drive an hour to get there and an hour to get back. Then that means that there's 8 units that I'm going to add to this. And then maybe the participants are more than just the client only. Maybe it's clients and others. And let's say the caregiver was present. And so I'm going to update this note header as new information, or before I'm finalizing this note, I can update that. Presenting problem, I might say the client presented with panic attacks. Oftentimes, I'm going to start my assessment with what brings you in for services, and then I'm going to listen and just allow them to process and to be able to share. I'm going to use reflective or active listening techniques, showing nonverbals and verbals, that I'm there for them and that I'm listening and I care about what they're saying. Oftentimes, that will allow me to deduce answers to a lot of information in my intake assessment that I don't necessarily have to ask that explicit question, because they give me the information through them sharing of the story in a very natural way. I also want to note that many times we have spelling errors or something like that, or there might be abbreviations or very short, grammatically incorrect type of sentences. Many very busy practitioners and providers don't necessarily concern themselves with that. So this is not a spelling test. Don't be concerned about small errors like that in your notes. Every intake must have a mental status exam within that. You can also see that there are options to be able to help you answer what is the most appropriate answer for your client. And so every intake assessment must have a mental status exam, and every single item in this intake must be complete. So this is a requirement for every intake. If you're doing a progress note that maybe doesn't require or doesn't involve the client, then you may not have that information, but every intake must have that information. If everything is normal, then you can click all normal. But every one of these items must be answered. Also, risk assessment. You want to be able to ask if there have been any homicidal ideations or thoughts or plans or attempts in the past. Have there been any suicidal attempts or suicidal thoughts or plans? And you want to explicitly ask that question. In that, you're going to then answer what are those areas of risk, and you can add multiple areas of risk based on the number of things. You're going to learn about their intention to act, their plan to act for each one, means to act. What are some of the risk factors, which are going to be listed in some of these? What are some of the protective factors? But you might have protective factors, but you may also add your own that you might feel like are important protective factors. And so you want to list those things. And then based on the risk factors, protective factors, intention to act, plan to act, means to act, you're going to make a determination of what level of risk. If it's high or imminent risk, then in those situations, you want to make sure that you are doing some type of crisis management plan, or connecting them with mobile crisis response, or calling your supervisor in those situations. So you're going to do that. You're then going to add additional information that might be here, what type of objective content that might be collected during the session, or what was the session like. And so many times we are going to be documenting that the therapist provided information about consent and limits of confidentiality, because that is something that you're going to be doing in that initial meeting when you're going over the Stress and Trauma Treatment Center consent form. Now, each one of these areas must have an answer and need to have a lot of detail. So an intake assessment may take you 2 hours. It may take you an hour and a half. It could take 3 hours, and it's okay if it takes you that long, as long as the consumer continues to be engaged and that this is part of the process they want to participate in. We want to include, and you can see kind of the information that's needed here. It will give you a clue that they're 17 at the time of intake for this particular client. You want to have their age, ethnicity, religion, marital status, referral status. Where did they get referred from? You want to talk about symptoms, what brought them in now, what's the duration of that, when did they start? When did they start, if it's substance use, when they start using, et cetera, et cetera. How long have they had the symptoms? What's their past diagnosis or current diagnosis, different courses of treatment? You want to talk about what types of trauma have they experienced? What type of adversity have they experienced? When did it occur? Who was involved in that? Do they have any current threats, et cetera, to that? History of mental illness for family psychiatric history, past diagnosis for the family, and et cetera, et cetera. So you want to go through each one of these and you want to have explicit information. The intake assessment should not be a really short assessment. It should have a lot of comprehensive information that really gives you the overall picture of their history, psychosocial history that have led to this, so that you can see from a developmental, social, family history, substance use, medical conditions, overall the whole person, to be able to get a picture of what's happening in their life that then leads to what might be the next piece. Sometimes you might be continuing into treatment planning or providing services, whatever that might be a psychological evaluation if they need that, if it's more complicated than that for you. Um, every intake assessment will end with a diagnosis. Many people feel apprehensive about diagnosing. They feel like they're not capable or they're not trained enough in that. Do seek supervision to be able to develop in your ability to be able to diagnose. But all intake assessments need a diagnosis, and this diagnosis can't wait until later on when you have a meeting or you have the ability to have 3 meetings with your family before you get to diagnose. So you do want to end with a diagnosis. In your diagnosis, you can find yourself finding the code for this by just starting to diagnose or starting to type in what it is that's going on. So with this person, maybe there's certain stressors that might have contributed to this. And so you might then diagnose them with adjustment disorder with anxiety. Here, you want to give a diagnostic justification. This justification, it needs to read something like this, but you want to be able to give justification of why this diagnosis is true. And so the client is a 17-year-old male female that identifies as a transgendered individual. The client was referred by her primary care provider. And in this, oftentimes I'm going to try to use the pronoun that that person has said that they want to identify as. Client has had panic attacks. And here I'm just going to summarize some of the information that was there off and on for the past year. The client started to have panic attacks following, again, some kind of presentation of a stressor. And this is where I'm going to get to the justification and general anxiety following coming out to her parents being transgendered, about identifying as transgendered. When we look at adjustment disorder or serving individuals that might identify as LGBTQIA, what we might end up finding is that it's the stressors, right? It's not the identity, but it's the stress that comes along with maybe living in a society or in a community or in a culture or in a family that may not be supportive or might have certain types of stresses that are there. As transgendered, the client reported this is an ongoing stress and that frequent invalidations, as an example, occur. where the client does not get called by their preferred pronoun. That creates significant anxiety and invalidation as an example. This stress and anxiety, or this anxiety did not occur prior to coming out and being treated differently for identifying. Individual. All right, so in this, we want to say something like client's age is this, living in, I'm going to add that here, living in El Dorado, Illinois with her mother and father, referred by, what are the symptoms, and then we're going to give a little bit of a picture of all of this. The client meets criteria for whatever it is that you're going to diagnose: adjustment disorder with anxiety, demonstrated by increased anxiety and the presentation of panic attacks following coming out and sharing about being transgendered with her family 1 year prior, and continued stressors associated with being invalidated, or the family rejection of her current gender identity. All right, so something like that, and then we're going to sign the form that's completed in all of this, and then we're going to create a note at that particular point. Now, of course, it says there are several different areas I did not do at this particular point, but once you sign that note, then it'll go over to your supervisor, that then will have the opportunity to review your justification, the diagnosis, and we'll be able to give you feedback in that. It's easy to want to avoid the uncomfortableness of diagnosing or the lack of confidence in doing so. Many times we're going to diagnose with adjustment disorder or things that might be less impactful at the initial diagnosis. And then as we learn more, we may then update the intake at a later date. This concludes a video on how to create a note, create an intake note, and complete an intake for a new consumer in services.